सिद्धिविनायक शरणु वेद्यप्रदायक शरणु सिद्धिविनायक शरणु वेद्यप्रदायक शरणु पार्वती तनयमूर्ति शरणु मूषिक वाहना शरणु पार्वती तनयमूर्ति शरणु मूषिक वाहना शरणु सिद्धिविनायक नितिलनेत्रन देवी सुतने नागभूषण प्रियने नितिलनेत्रन देवी सुतने नागभूषण प्रियने तटिलताङ्कित कोमलाङ्गने कर्णकुण्डल धारणे तटिलताङ्कित कोमलाङ्गने कर्णकुण्डल धारणे शरणु सिद्धिविनायक कुक्षिमहालम्बोदरने इक्षुचापनकेलितने कुक्षिमहालम्बोदरने इक्षुचापनकेलितने पक्षिवाहन श्रीपुरन्दर विठलना निज दासने पक्षिवाहन श्रीपुरन्दर विठलना निज दासने शरणु सिद्धिविनायक शरणु वेद्यप्रदायक शरणु पार्वती तनयमूर्ति शरणु मूषिक वाहना शरणु सिद्धिविनायक शारदे करुणानिधे सकलानवाम्ब सदा जना चारणादिमगीतवैभवपूरिता किल दीप्तते शारदे करुणानिधे सकलानवाम्ब सदा जना.
Please remain standing as we'll hear the Tamil Thai Valtu. You may all be seated. Thank you so much. Now we will formally launch the event with the lighting of the lamp. I request the dignitaries and the honored members of DClub to kindly make it to the dais. Thank you so much. As we conclude the inauguration ceremony, I humbly request the audience to rise as we sing the national anthem as per tradition. Thank you. Please be seated. With that, we are now going to have the Professor Dr. V.T. Balaraman oration delivered to us by our chief guest, Dr. Shanmugavel. I request our organizing chairman, Professor Dr. P. Paranthaman, to introduce us to the speaker.
Very good afternoon, everybody. It is my pleasure and honor to read out the citation of the orator, the eminent physician diabetologist, Dr. N. Shanmugavel. The DClub and the organizing committee of DCCon 2024 has immense pleasure in honoring the eminent physician and diabetologist, Dr. M. Shanmugavelu is MD, FICP, FRCP Glasgow and UK and Fellow of Royal College RSGI. A specialist in internal medicine and diabetology, is a chairman Trichy Diabetic Specialty Center. For delivering the most prestigious Professor V.T. Balaraman oration. The talk oration is Inter-organ metabolic crosstalk in diabetes mellitus. On Saturday, 13 July 2024 at Ramada Plaza, Gindi, Chennai. Dr. M. Shanmugavelu is graduated in the year 1980, MD Internal Medicine in the year 1985 from Government Kilpauk Medical College, Chennai. He received fellowship of FRCP Glasgow, UK in the year 2015. FICP, that is Indian College of Physicians, in the year 2016. RSGI Fellowship Award in the year 2020. He has been served the Tamil Nadu Medical Government Service during the year 1981 to 1992, and he has a best academic member, active member, both state as well as national RSGI. He is a past secretary of RSGI Tamil Nadu chapter, and he has been the regional faculty for Public Health Foundation of India in Delhi from 2010 till date. He has published more than 50 articles in both national and international reputed journals, and for his excellence. He was honored with Professor M. Samjipi Oration Award in DCCon 2017 at Madurai. Economic Times Inspiring Diabetologist of the India Award at Delhi in the year 2018. Dr. Arul Raj Guest Lecture Award in Tapicon 2018 at Kodaikanal. Dr. M.S. Ashraf, Doctor's Day Award in IMA Trichy branch. And RSDI UP State Chapter, UPCon 2024 RSDI Commemorating Oration Award was given for his excellence. Dr. Meenakshi Sundaram Shanmukhavelu is a principal investigator for many trials, primary trials and both phase 4 and phase 3 trials, especially SRID, insulin degludec plus, and HOPE-D trial, a TECOS trial, and TECOS trial, and so many landmark trials. He was a principal investigator of epidemiological studies of solid and in-depth insight, etc. DClub and the organizing committee of DCCon 2020 is pleased to present this most prestigious Professor V.T. Balraman Oration Award to Dr. Meenakshi Sundaram Shanmukhavelu for recognition of his meritorious service in the field of diabetology. Thank you, sir.
This one for advancing. Right. Senior doctors, my doctor friends, and of course former friends, I feel extremely happy, honored, and most privileged to have been invited to deliver Professor Dr. V.T. Balaraman's Oration Award. I may fail in my duty if I do not thank all the organizing committee members of DClub Con 2024. Can I have the slide? So DCCon 2024, Professor V.T. Balraman's Oration. My tribute to Professor Dr. V.T. Balraman. Professor V.T. Balraman, an esteemed honorary professor of medicine at Madras Medical College, has established a distinguished reputation within the medical industry, specializing in tropical medicine and diabetes. He enjoyed a successful career over 4 decades at Madras Medical College, where he once oversaw the Department of Diabetes at MMC and garnered great acclaim for his exceptional skills at a young age. His gentle demeanor, generosity towards deserving students, and unwavering commitment to ethical practice have earned him the loyalty and affection of his patients, colleagues, friends, and family. Beyond his medical pursuits, Professor V.T. Balraman is revered for his eloquence in Tamil and English, captivating audiences with his extemporaneous speeches in a deep, resonant voice. His remarkable memory to recall names and phone numbers, his love for fine cuisine, music, Tamil literature, and speeches of Thirukirpananda Variyar are just a few traits that set him apart. Influenced by esteemed mentors like Ayya, Professor Dr. Ratanavel Subramaniam. I don't know how many of you remember Professor Dr. R.S. Ratanavel Subramaniam, Professor Dr. Samjeev Moses, Professor Dr. M.S. Amarasan, cardiologist Professor Dr. Sankaran, and Professor Dr. V. Sachaya, as well as close friends. Professor V.T. Balraman has emerged as a true role model, embodying respect, inspiration, integrity in all his interactions. Professor Dr. V.T. Balraman's passion for his profession is evident in his close association with his patients, peers, and students, always offering words of kindness and hospitality over the years. His legacy as a dedicated physician and a compassionate human being will be forever cherished by those fortunate enough to have crossed paths with him. In fact, I did my senior house agency under Professor Dr. M. Thayamanavan, I happened to interact with V.T. Balaraman during the time, whenever he made rounds in intensive medical care. Not only that, when I did my 4th MBBS in 1977, there was an exhibition organized by Professor Dr. B. Kizar Ahmed. That is the exhibition for the patient with the diabetes. At the time, Dr. Sam G.P. Moses, Kizar Ahmed, U. Muhammad, and Dr. V.T. Balaraman, they were standing. I asked Dr. V.T. Balaraman and Sam G.P. Moses one question. Sir, can we give insulin in the night time to patients with type 2 diabetes? He said, why not? Sir, night time we never give any meal after 9 o'clock. The chances of risk of hypoglycemia will be more if we give, and we need to monitor very closely. He said, when the indications are compelled, you are supposed to give. Second time, there was a program organized in World University Service, CHETPET, in the year 1980 or 79. They collected a registration fee of rupees 10. In fact, that conference was supported by, I think, Pfizer, next is USP, Alembic, and Kext, not Aventis as of now, Kext. They were the real pharma industry marketing the products for the management of type 2 diabetes. That is dianyl, rastinon, alkamide, next is cadila also, chlorphormine. That time, the concept of diabetic WBC, platelets, coagulation profile changes, fibrinolytic system was introduced. Along with that, they brought the role of yoga at that time. I stood up and asked Dr. V.T. Balaraman, if a normal man does yoga, what will be the chance of developing he or him hypoglycemia? He said, no. Patient with diabetes, when they do yoga, definitely they will get, it will offer them very improvement with reference to glycemic control. These are all my questions with reference to V.T. Balaraman, and my sincere thanks to my friend Dr. Dhanamitran, Professor Dr. Parandaman, Dr. Natarajan, Dr. Jaykumar, and U.V. Mohan for inviting me and also honoring me in this august presence. So, inter-organ metabolic crosstalk in diabetes with a particular focus on evidence-based findings, and of course, I thank every members of this particular organizing committee and my disclosures. So, what I am going to do for another 20 minutes, the contents of my talk line includes introduction, background, inter-organ crosstalk under physiological conditions. Next is inter-organ crosstalk in MED syndrome, and the causes for beta cell dysfunction, of course, conclusion. So, in order to maintain homeostasis, adapt to external conditions, the different tissues of multicellular organisms communicate with each other via multiple signals. Peripheral organs, they produce a plethora of bioactive molecules, including hormones, that ensure intercellular signaling in an autocrine, paracrine, or endocrine manner. Peripheral organs and immune cells produce cytokines that also participate in inter-organ communication. Nervous system coordinates not only by the production of neurohormones, but also by direct invasion of the target tissues. Sympathetic, parasympathetic fibers, they express enzymes for the biosynthesis and transport of specific molecules like neurotransmitters and neuropeptides. Claude Bernard suggested that system involving chemical messenger ensures a communication between the different organs of the body. The term hormone was first used in 1905 by the British physiologist Ernest Starling to describe the gut hormone secretin that is first described just 3 years prior. Pancreatic insulin and glucagon were successfully identified, synthesized, and used for therapy in the course of 20th century. The identification of signaling molecules like hepatokines, myokines, adipokines, beta-kines to describe the hormones produced by liver, muscle, white adipose tissue, and brown adipose tissue respectively. Signaling molecules, they respond to fasting feeding cycles, circadian rhythm, cold exposure and exercise, thus participating in organism's adaptive response and ensuring metabolic flexibility. So, inter-organ communication that is altered in different pathological conditions like obesity. So, pharmacological interventions to modify the production of hormones, cytokines, or directly delivering recombinant hormones or cytokines are being explored as promising approaches to treat a variety of obesity-related endocrine diseases. So, inter-organ crosstalk under physiological conditions. So, under feeding conditions, So food ingestion stimulates the secretion of gut hormones. We have the GLP, secretin, LEAP, insulin, leptin, fibroblast growth factor 19, right. These GLP and secretin stimulate insulin, reduce glucagon secretion. Fibroblast growth factor reduces bile acid synthesis. Leptin acts in the CNS to repress food intake. Overall, these gut hormone signals to the brain to reduce food intake. Under fasting conditions, so fasting stimulates the secretion of various hormones. So we have ghrelin, glucagon, FGF21, adiponectin, asparagine. So ghrelin targets the brain to increase food intake, increases glucagon secretion. Glucagon increases hepatic glucose production and induces lipolysis. And FGF1 increases lipolysis. Asparagine and adiponectin decrease energy expenditure and promote food intake. Next is under cold exposure, inter-organ communication. So cold stimuli sensed by the neurons in the skin, they activate the thermoregulatory hypothalamic regions of the brain. So we have the orexin, next is bone morphogenetic protein 8, next is sympathetic nervous system, next is thyroid stimulating hormone. Sympathetic nervous system stimulates norepinephrine secretion. Hypothalamic pituitary axis, they contribute to the activation of bad thermogenesis. Muscle shivering promotes release of hydrasin that in turn causes thermogenesis. So fibroblast growth factor 21 and bile acid secretion contribute to the browning of fat. Next is during exercise. Aerobic exercise or strength training trigger the secretion of numerous myokines. We have interleukin 6 that mediates muscle glucose uptake, insulin sensitivity, insulin production, hepatic glucose production, ensuring the availability of energy substrates. Irisin triggers the remodeling of white. So white adipose tissue becomes brown and therefore it gets involved in thermogenesis. It increases muscle oxidative metabolism as well as reduces hepatic glucose output. FGF21 reduces muscle insulin resistance. Overall, physical exercise promotes browning of fat and bad thermogenesis to meet the increased demand for fatty acid and glucose oxidation. Communication from the gastrointestinal system to pancreatic islets, we get the incretin, serotonin, ghrelin. These hormones play an important role in the regulation of nutrient uptake and storage. So they modify energy metabolism and also have diverse metabolic effects on target organs. So communication from the gastrointestinal system to the central nervous system. We have the GLP. So the signals are transmitted via the vagus to the nucleus tractus solitarius or the area postrema, and several portions of the brain, they express the glucose GLP-1 subcharts, including the arcuate nucleus in the hypothalamus. In turn, GLP activates the POMC-COT neurons, and at the same time inhibiting the neuropeptide Y agotic-related peptide neuron, and the whole signal result in satiety or reduced food intake. So the effect mediated by GLP-1, GIP, we know the important with reference to GIP is it increases adipose tissue insulin sensitivity. We have the glucagon, that increases glucose production, satiety, energy expenditure, promote weight loss, improvement in glycemic control, decreases liver fat as told by our gastroenterologist. So the clinically most relevant mechanism of action of GLP-1, GIP, glucagon with reference to insulin secretion, glucagon suppression, weight loss, energy expenditure. So the evolving GIP and GLP partnership in metabolism. We have the effects mediated by GLP, effects mediated by GIP, combined GLP and GIP with reference to food intake, weight loss as well as insulin secretion. We have the unimolecular monoagonists like liraglutide, exenatide, dulaglutide. Combining GIP, GLP, we have the twin cretins, that is unimolecular co-agonist. And we have the two components, they bind with the respective receptors that is present in the different targets or the tissues, ultimately potentiating insulin secretion, improves glucose tolerance and result in significant body reductions. So we have the mono, dual and triple agonism, exenatide, lixisenatide, and we have the liraglutide as monoagonist. That is mainly, that is promoting insulinotropic and insulin sensitizing property of GIP, anorexic effects of GLP-1, thermogenic and lipolytic effects of the glucagon. Combining GIP, GLP-1, we have the tirzepatide. Combining GLP and glucagon, we have the cotatutide. Combining all the three, we have the retatrutide. So communication from the gastrointestinal system, gut microbiota associated signaling molecules. So gut microbiota convert environmental signals and dietary molecules into signaling metabolites. So we have these short chain fatty acids, bile acids, branched chain amino acids, and of course the lipopolysaccharide. These gut microbiota are associated bioactive compounds. They can signal to different organs and tissues in the host to modulate the function of these organs and tissues. So the microbiota influence on glucose homeostasis with reference to GLP, with reference to gluconeogenesis, also improving insulin sensitivity or inducing insulin resistance. In the presence of inflammation, the lipopolysaccharide level goes up. It alters the mucosal permeability, causing bacterial translocation and metabolic endotoxemia. Bile acids play an important role with reference to glucose metabolism through primary and secondary bile acid metabolites. So flow charts representing the effect of diet pattern on bacterial population. So diet rich in plant material, that results in improvement in gut mobility, insulin sensitivity, thereby making the gut non-leaky. Animal product that causes reverse effect, induces insulin resistance, inflammation, and make the gut leaky. So the main mechanism between gut microbiota and type 2, very important thing is they maintain the intestinal mucosal barrier, intestinal epithelial integrity, and also glucose metabolism. So gut microbiota alters host homeostasis through production of metabolites, activation of inflammatory cascades, disrupting the permeability of the intestinal mucosal barrier, and direct signaling action through incretin system. So the bariatric surgery, yet another communication from gastrointestinal system to pancreatic islet. So immediate impact of surgery is caloric restriction and enhanced nutrient and bile delivery to the mid-distal jejunum and ileum. And these are all the potential mediators. Alteration with reference to bile acid signaling, microbiome, gut hormones, neural signaling, intestinal adaptation, reduced hepatic and pancreatic triglycerides, improvement with reference to the glycemic status. So communication from liver to pancreatic islets, we have the liver-derived factors, hepatokines. These hepatokines, lipids, and other small molecules, they have diverse effect on target organs, including adipose tissues, brain, and cardiovascular system. Next is the communication from adipose tissue to pancreatic islets, adipose tissue derived factors. We have the adipokines, secreted molecules signaled to brain to regulate energy metabolism, and others including adipokines and lipokines, they have diverse effects on their target organs. Next is from muscles to beta cell. Skeletal muscle is the largest organ, major site of insulin and exercise mediated glucose disposal. So we have the interleukin that is produced by skeletal muscles during exercise. It promotes GLP-1 secretion. It also improves beta cell function, not only beta cell function but also improves insulin sensitivity. Next is from nerve cells to pancreatic islets crosstalk. Pancreatic islets are innervated by parasympathetic and sympathetic nervous system. In hyperglycemia, the parasympathetic nerve releases acetylcholine that in turn potentiates insulin secretion. And we have the other parasympathetic nerves also release other peptides like vasoactive intestinal peptide and gastrin-related peptide and so on. In contrast to hyperglycemia induced activation, hypoglycemia, it stimulates the sympathetic nervous system, induces glucagon secretion. If you look into the postprandial glucagon secretion, it is influenced by the nutrient and also partly regulated by the parasympathetic input. Next is bone to beta cell crosstalk. Bone is again considered as an endocrine organ. Osteoblast specific secreted molecule osteocalcin enhances insulin secretion, improves insulin sensitivity as well as energy expenditure. Insulin signaling in osteoblast, it facilitates bone resorption. So there is an interplay between beta cells, osteoblast as well as osteoclast that regulates beta cell function as well as whole body glucose metabolism. So inter-organ crosstalk in MET syndrome. VAT, white adipose tissue, accounts for more than 50%. Patient with obesity, they exhibit high plasma levels of leptin. So hyperleptinemia, just like hyperinsulinemia. In addition to leptin level, there occurs leptin resistance. So the improvement what we see with reference to reduction in the food intake and increase in energy expenditure is not observed or not seen in the presence of hyperleptinemia and leptin resistance. And this pathologic leptin signaling also results in increased hepatic glucose output. Not only that, there is reduced thermogenic activation of BAD as well as overall energy expenditure. And this circulating asparagine also induces hyperglycemia by inducing insulin resistance. These are all the alterations of the inter-organ communication in obesity with reference to leptin, neuropeptide Y, adiponectin, fibroblast growth factor, asparagine. And we have the methionine-liking protein 4, GLP-1, interleukins, as well as myostatin. Next is alterations of inter-organ communication in non-alcoholic fatty liver disease, of course enumerated by our gastroenterologists. These are all the contributing and modulating factors, and these are all the pathophysiological changes that occur inside the hepatocytes, ultimately resulting in inflammation, oxidative stress, and inflammation activation, resulting in fibrosis, hepatocellular injury, stellate cell activation, and fibrogenesis. Next is alterations of inter-organ communication in atherosclerosis. These are all the contributing factors and modulating factors, ultimately resulting in the genesis of the atheromatous plaque through the deposition of LDL particles and the activation of the various immune cells. So, infiltration of atherogenic lipoprotein, additions of blood leukocytes, migration of monocytes, extensive proliferation, and collagen synthesis. Next is inter-organ crosstalk contributing to beta cell dysfunction. So, inter-organ crosstalk involved in beta cell failure, big of the hepatokines, big of the myokines, big of the bad kinds, right. So, adiponectin have protective effects on beta cells. Leptin impacts beta cell function. And this free fatty acids spill over from adipose tissue, induces insulin resistance. Skeletal muscle and liver might exert detrimental effects on beta cell function. And intra-amyloid polypeptide, they promote inflammatory response through promotion of interleukin 1 beta. So, obesity and type 2. Obesity, it refers to chronic inflammatory state, including type 2 diabetes. And that this inflammation have an impact on the progressive development of beta cell failure. In response to glucolipotoxic environment, beta cell also releases certain pro-inflammatory factors along with the inflammatory cells like macrophages and immune cells, which can also causes the release of various chemokines and cytokines. These chemokines in the presence of lipid level also forces the beta cells to produce islet amyloid polypeptide, and this results in progressive failure of the beta cell function. Next is exocrine and endocrine crosstalk. Chronic pancreatitis, cystic fibrosis, they are associated with islet dysfunction and diabetes due to injury, inflammation, and fibrosis in the acini. Inside the islets, with reference to the pancreatic ductal adenocarcinoma, the beta cells are dedifferentiated in patient with the pancreatic ductal adenocarcinoma. What causes beta cell dysfunction? So we have glucotoxicity, lipotoxicity, inflammation, oxidative stress, altered gene expression. So the beta cell compensation and dysfunction in MET syndrome. Early stage is characterized by hyperinsulinemia in the insulin resistant. That clearly shows the beta cell ability to secrete enough insulin. Over time, in a subset of patients with type 2 diabetes, that develop beta cell dysfunction. And this dysfunction of beta cell is characterized by endoplasmic reticulum stress, mitochondrial dysfunction, giving rise to either beta cell apoptosis or dedifferentiation or transdifferentiation or altered beta cell mass and with a characteristic loss of failure of the beta cell function. So we have the mRNA as well as long non-coding RNA. They also play an important role in beta cell dedifferentiation, beta cell loss and dysfunction. Next is beta cell differentiation definition. Loss of mature differentiated beta cell features primarily associated with insulin secretion. It refers to beta cell degranulation. In fact, the beta cell identity is tightly regulated by many essential transcription factors. This adoption of the dedifferentiated phenotype is a protective mechanism to support beta cell survival under conditions of stress and is reversible under specific conditions. And we have the transdifferentiation, there is direct conversion of terminally differentiated cells into other cell types. Alpha and beta cells, duct cells into beta cells, eosinophils into beta cells, and hepatocytes into beta cells. These are all the metabolic inter-organ crosstalk in the development of type 2, metabolic connections in inflammation and insulin resistance, and the evolving concept, so hyperglycemia, induces glucolipotoxicity, that results in loss of insulin content and mature beta cell identity. So loss of fully differentiated beta cell phenotype is recognized as the most likely mechanism underlying type 2 diabetes, and several work has identified markers of dedifferentiation in islets of patients with type 2. So overall conclusion, numerous extrinsic pathways and intrinsic mediators underlie reduced beta cell function and reduced beta cell mass. So in the presence of insulin resistance under glucolipotoxic condition, various extracellular signals from various organs modulate cellular responses. From such a viewpoint, inter-organ regulation may play a causative role in the type 2 diabetes, at least in part, by modulating the process that render beta cells unable to respond to increased metabolic demand. So if you look into the 2-pound coin, you can see what is written on it. Standing on the shoulders of giants. Today I am standing before you because of my doctor friends from Teacher Diabetes Specialty Center, IMA, Diabetes Club of Tiruchirappalli, RSSD National Tamil Nadu Chapter, Metabolic Club of Kumbakonam, Diabetes Club of Dindigul, Tanjore, Madurai, AP Tamil Nadu Chapter, Trichy and Madurai chapters. So thank you very much for your kind listening and patience.
Thank you very much, sir, for a wonderful presentation. Real oration, really we enjoyed you. Latest update on the beta cell hormones, inter-organ talk and cross-talk. A great presentation. Really, we owe to you. It's a wonderful presentation. Thank you very much. Since it is an oration, there is no questions at all. Welcome.
Thank you so much.
Sir.
Thanks a lot.
Thank you, sir.
Thank you, sir. We will now move forward to one of the highlights of our conference, which is the reverse panel. Our esteemed panelists, moderator and discussants all bring a unique perspective to the table and will be discussing in depth about managing diabetes in the young. With that, I'd like to welcome Professor Dr. S. Venkataraman, who will be our moderator. Sir is a senior consultant diabetologist at Apollo Hospitals, Chennai, as well as at Surya Hospital. He has authored books. He has contributed chapters in the Handbook of Diabetes and on peripheral vascular disease in the Textbook of Diabetes edited by Dr. Senani. He has received the International Diabetes Federation Award for his paper on pregnancy and diabetes at Washington and the Lifetime Achievement Award by the Indian Medical Association. Sir, we welcome you.
Dr. R. Madhavan sir. He is a professor of diabetology, Dr. Ambedkar Institution of Diabetology, Government Kilpak Medical College. He has 38 years of teaching experience of UG and PG Medical College. Sir, we welcome you, sir. Also, would like to welcome Dr. G. Vijay Kumar sir. He is a diabetologist, Apollo Specialist Hospital, Diabetologist Medical Care Center. Sir, we welcome you, sir.
Also have two discussants today. Dr. R.P. Rajesh, he's a consultant diabetologist at Ardhavan Diabetes and Research Center, as well as at Deepam Medfirst Hospital and the HVF Hospital of the Ministry of Defense, Avadi. He has formed the Chennai Diabetes Forum, through which various CMEs are conducted in diabetology. He is involved as a faculty and as a part of organizing committees in multiple conferences and as part of certificate courses. Sir, we welcome you. Graduate teaching programs. About Dr. Major Gauri Shankar. Sir has served in the Indian Army between 2003 and 2008 and is decorated with 4 medals. He is a member of various societies including the API, RSSDI and the ISA. He is passionate to learn, talk, travel, teach, cook and photograph people. Sir, we are honored to have you with us.
Gauri. Sir. It's a pleasure to be. Thank you, sir. Good morning, bar afternoon, friends. It's 12 o'clock. I think that was a very fluent oration by, as expected by my friend Velu, Shanmuga Velu. In fact, Velu and I have been undergraduate students, separated by just a year in the undergraduation and then probably in the same batch in the post-graduation. So always interested in the theoretical aspects of medicine, especially diabetes. So it was just a good revision and excellent exposure of the relevant science. Now, I think continuing from where he started, I think Professor V.T. Balraman was always good in Tamil, especially Tirukural. And I came from Hindu high school. Our school slogan was Karka Kasadara Karpavi Katrapi Nirka Dirkataha. Whatever you learn without blemish, and having learned without blemish, try to practice it. I think that is the motto of many scientific programs, especially the DClub, which I think my friends have started more than about a year back, I mean a decade back, and doing human service with respect to dissemination of knowledge, and I'm happy to be part of many of your activities, or almost all your activities, and really, what shall we say, pleasant to realize the growth and see the growth that DClub has taken with respect to dissemination of science. Thank you, Dr. Natarajan, Dhanmitran, Parandaman, and Mohan, for all the affection that you have, and also the respect that you have, and then the eagerness with which you want to learn and then disseminate. I think that's one of the aspects of medicine, which is the eagerness and the perfection with which you want to learn it and then share that knowledge with your colleagues, students, and friends. I think that is the purpose of this particular meeting as well, as I have seen it. Wonderful deliberations. Now, when it comes to the topic of discussion today, I think in diabetes, always the challenges are in management. In fact, if you have a, what shall we say, a debate or even a plenary lecture, I don't think many of us will see eye to eye on whatever has been translated, because this gives scope, tremendous scope for coupling your theoretical knowledge with your own practical experience. So, management of diabetes is always a problem. Of course, the guidelines, consensus guidelines are there, but the individual clinician has got his own prioritization of the molecules or the target that he has in mind, which is not far away from the evidence-based medicine. So, this is with respect to management. Quite often, since we deal with most of the diabetic subjects who are type 2 diabetic subjects, diagnosis is not always a challenge. The challenge is always a management, identifying the comorbid conditions, and then other aspects. Now, there are a subset of patients wherein diagnosis is a challenge. And that is the purpose of today's discussion. So, when an 18-year-old or 20-year-old or 25-year-old girl or boy, with or without obesity, presents with a high blood sugar level, I think basically, with the clinical presentation, with your knowledge, you should have a comfortable level of confidence to make a clinical diagnosis and then substantiate with the relevant guidelines. I think the purpose of today's discussion with my learned friends, Professor Madhavan, Professor Anand Moses unfortunately couldn't be here to share his thoughts with you, and Dr. GVK, and of course ably assisted by my friends Dr. Rajesh and Gauri Shankar, is to present about 3 clinical cases. And what I want to share with you is, ladies and gentlemen, these are all real-time cases. These are all real-time cases as has been captured. So not necessarily the presenters, Rajesh and Gauri, has been involved in the treatment of these. Many healthcare providers have been involved. Reputed diabetic institutions, reputed diabetologists, endocrinologists. So what I'm trying to say is, it has been presented in such a way that what has happened. Now it is up to us, my 2 panelists, my great friends who have got enormous knowledge and experience, and of course, wherever is, I mean, whatever I feel, I'll also give my inputs, filling the absence of Professor Anand Moses. So the purpose is to go through these cases so that we have some clarity with respect to establishing a diagnosis in a young diabetic. So without wasting much time, I think the diabetes in the young, so this is a reverse panel. In other words, the case will be presented slide by slide. I think we are going to give our thoughts. Then possibly what has happened in the real scenario, maybe time permitting, we'll have some audience participation also if my fellow panelists, Professor Madhavan and Dr. G.B.K. say. Now I request Dr. Rajesh and Gauri to occupy, and once again thank for the excellent spade work. Whenever we do a program, always these two are behind us to guide us academically, and so is this program as well. Thank you, Rajesh.
Thank you, sir. So I would like to thank the entire team for involving us in this program. I'd like to thank the opportunity given by Venkatraman sir, Madhavan sir and Vijay Kumar sir. What we are going to do in next, say, 55 minutes is, we are going to present 3 cases. As sir said, it is very, very raw. It is the same case which we had seen in our practice. We try to keep it as named as possible, so that we have done mistakes. We have done mistakes in understanding. So as we discuss, we will let us explore the mistakes that has been done and learn from these mistakes and make a proper diagnosis. That is the objective of this program. It is going to be challenging because it's a young people, so there will be lots of diagnostic dilemmas. That is what we are going to decipher. It is not going to be a question and answer session or an interview. We are going to present the case and we will discuss it with our teachers, like what we could have done better to improve the outcome in improving the understanding of these patients. That is the objective of this program. So with this, I would like my friend Dr. Rajesh, can you just go with the
Yeah, I'm absolutely ready. So before I could start, I want to, very good afternoon to all of you. Let me profusely thank our Professor Venkatraman sir for giving this opportunity, and also thank the organizers of DClub for giving this opportunity. And we have eminent seniors here, so where they are going, your knowledge and inputs on this case are going to be really precious, and we are eagerly waiting to gain knowledge from you regarding this case. So with this, let me straight away go into this case. So here, you have a very young patient, 18-year-old girl, Akshu. If you look into the BMI, it is 19.5. Obviously, it is not obese. As per the Indian standards, you can say it is normal also. Otherwise, definitely not obese. You can see it is 19.5 only. And she comes to us with a history of recurrent vaginitis. So this is the presenting complaints, recurrent vaginitis. So obviously, when somebody has genital infections, what we do, we usually do a random blood sugar, and there you can see it was 380 there, and the patient was surprised and shocked. She told, why is this so very high for me? Last year only I took a lot of sweets when I was preparing for my examination. Why is it so very high? She was a little confused. So then we looked into what was the HbA1c. You can see it was 12.8. Otherwise, she did not have any symptoms of diabetes, any classical symptoms, like she did not have, this was her usual weight. She did not lose any weight. There was no polyuria, polydipsia, all the classical symptoms of diabetes was not there, and absolutely asymptomatic. And we also did ketone there, and ketone was negative for this patient. So you want anything to add up here, Dr. Gauri?
Fine. This is the presenting case. Like the fundamental thing as this patient presents to us in our practice is, first she is an 18-year-old, BMI is about 19.5, and no features suggestive of insulin resistance. So these 3 points, presenting early with as Dr. Rajesh said, a normal BMI and no features of insulin resistance. She didn't have any viral what, acanthosis, she was not obese, her tummy was normal. So everything was normal. So are we looking at a type 1 over here, or her blood sugar is about 380 plus, HbA1c is about 12.8, and she is presenting with a history of recurrent vaginitis. So in spite of recurrent vaginitis, she is not going for any ketones positive. So as you see, like ketones are negative. So am I handling a type 2? So this is the fundamental question I want to understand from this case, whether it is a type 1 or type 2, sir.
Yeah, very interesting. Normal BMI, that is Indian standard is 21. Normal BMI, 18-year-old. But the most important thing is without ketone, and if you can see the random blood sugar is 3 to HbA1c 12.8, which is very, very, alarmingly high. Now, in this situation, there are no features of insulin resistance, that is number one, and no ketones are also
And
there.
menstrual cycles are also normal.
And I mean, if you think about type 1 diabetic, you know that most of the type 1 diabetes, I don't think they'll present as vulvovaginitis, but they come with more of a gross weight loss which they come. Usually if you see the type 1 diabetes, generally you can see that hardly they present with vulvovaginitis. I think this is the one which you need to think about, whether it is type 1, unlikely could be type 1 diabetic because of this.
What I feel is that, as Dr. Venkatraman was telling us in his introductory remark, in 90% of the cases, subjects, at presentation, it is not very difficult to arrive at the type of diagnosis. A good clinical history is what you require. You talk to the patient for 5 minutes.
So in this context, what kind of a history or what kind of a physical examination can be helpful for us to favor a diagnosis of either type 1 or type 2?
The most important thing I would like to ask is the mode of onset, whether it is an explosive onset or insidious onset. That is very important. That will give you a clue whether it is a type 1 diabetes or some other type of diabetes. Family history. There is nothing about family history here. Whether any of our relatives, blood relatives, were diabetic, and if there was a vertical transmission in 3 generations, that will give you a clue that it may be a, for instance, a Modi type of diabetes. So I think these 2 things are very important. That is not there. And I understand this is the presentation. When the patient came to you, that was the first time diagnosed with diabetes.
Sir, when we poked the history, she gave one important positive history that she presented with this recurrent vaginitis. When we asked like what was happening the last time, she gave a history of last time also when I presented like this, the doctor did the investigation, the blood sugar was 300 and 400 plus. I thought that it is all because of the chocolates that I was consuming during JE preparation. I didn't give much importance. So for about 1 year.
No, what would I like to know is, was she told that she has diabetes and treated? That's very important.
She didn't. So she said that sugar was so much last year also when I presented with this complaint.
Well, almost 1 year she didn't bother about.
She didn't.
Oh, okay. No history of hospitalization with acute metabolic decompensation.
No management. She didn't see any doctor for her sugars.
So all this history militates against type 1 diabetes. So it's very unlikely to be type 1 diabetes. A type 1 diabetic patient doesn't remain for 1 year with 400 and 500 without metabolic decompensation, ketosis, and at least 1 or 2 admissions. I think we have to look for other types of diabetes in this case.
Sir,
I think Dr. Madhavan is thinking about family history. It's a very, very important question he has raised. Usually a 3-generation transmission, it can be a Modi. But you know, Modi at the 18 years, is it likely to not to be there, Modi also? I think that's an aspect. Usually it's around 20 to 25 years Modi. But 18 years, that is 17 years. She is now 18 and she has got the symptoms for 1 year. Though the onset of diabetes seems to be around 17 years old, which also negates the possibility of Modi. And how about the family history? He's got any 3-generation transmission history?
Sir,
subsequently
we will discuss about that, sir.
Okay.
Now, sir, apart from the family history, do you think menstrual history has a role here to arrive at a diagnosis? No. Suppose if this patient has irregular menstruation,
you are thinking in terms of polycystic
PCOS, something like that. Could it favor
without that history, I don't think menstrual history is going to give any clue about the type of diabetes.
Okay, sir.
And one more thing is that when you talk about it, this is a very important case actually, you know, for discussion purpose. Suppose if it's a type 1 diabetes, most often type 1 diabetes happens around menarche, around 13, 14, 12, 13, 14. At least in India, what we found in VHS Medical Center is a huge rise during menarche, generally. And sometimes also we found that in June and December, where these usually viral infections can happen, at that time also it can happen. Just for the information sake, what happens in India as far as type 1 diabetes is concerned.
But also, I think Dr. Venkatraman will agree, we always used to talk about a special category of type 1 diabetes in India, slow onset type 1 diabetes. The destruction of beta cell is not complete at the first instance. It's a very slow process. So initially they may not have the explosive onset. That is very common in India. We have seen many number of cases. So this case, if you take that into consideration, still possible that this is a type 1 diabetes.
Sir, so with this ambiguity lying over
I
there,
add one point, Gauri.
Sir.
I think again for the audience I want to tell, this is a real-time case. So that's why the discussion has been, had it been also. See, if you had a simulated case, we would have changed the BMI and we would have added something. This was exactly so. A case like this, I think in the clinical parlance, when this patient first presents, you always make a diagnosis of query type 1 diabetes. Yes, ketones are negative, and she has been without treatment for 1 year. No, she is not going for metabolic decompensation. Yeah, those are points, but still you should have an working diagnosis at this stage. So it will be a query type 1 diabetes, and you will initiate the patient on insulin. History-wise, as has been, yes, family history of diabetes. For example, this patient, had she had acanthosis nigricans, had she been obese, had she had PCOD, then certainly you would have had features of insulin resistance. Your diagnostic tilt will be towards a younger onset type 2 diabetes mellitus. If we did not have all those things, so still at this stage, you can always say a query type 1 diabetes. Maybe just for theoretical consideration, any history of a viral fever preceding the onset of symptoms, but that becomes meaningless because the patient has been without treatment for 1 to 1.5 years, and still she has not lost much. I think MODI you can have. See, classically when we say 25-year cutoff, there is a cutoff. I have had cases of MODI, suspected MODI, MODI 4, H1F1 alpha. In fact, she was on insulin, young girl whom I saw in SMF. I think Samukarna will remember it. So that girl was related to one of her friends, Dr. Jaya Subramaniam. Now she should be around 40 years old. I started her on insulin. Subsequently, she was on OHE. Of course, she got married at that time. What I'm trying to say is, this is an age group wherein lot of diagnostic possibilities exist. So at this stage, I think the diagnosis should be.
Sir,
yes.
One point, sir, I need also clarification from you. If it's a MODI, do you think that they'll be so explosive? MODI usually will not be having HbA1c of 12.8 and 380. So it's unlikely because of.
There are various types of MODI, as I think we discussed in the previous also. See, the glucokinase deficiency is probably the mildest form of MODI, which makes its announcement only during the pregnancy. Then they are probably do not have much of a problem throughout, and there are data to suggest even they may not go in for any complications. In other words, it is a situational determined hyperglycemia warranting some treatment episodically. Whereas you have the HNF1 alpha and 4 alpha, wherein the presentation, or more importantly, the progress of the disease can be in such a way that good number of them may require insulin. Even though it is a transcription factor defect, the defect could be so severe that you may not be able to control, even though classically they are supposed to respond to sulfonylureas, they may require. In other words, the clinical spectrum of the MODI is so widely separated that it can mimic a type 1 diabetes, it can mimic a pre-diabetic, it can mimic a type 2 diabetic mellitus, and of course, and other things are just for completion's sake, the patient is young. I also look for other evidences, for example, lipodystrophy. Is there any uneven distribution of the fat or lack of fat? So these are the things. So family history of a viral fever, vertical descent for dominant pattern inherit, if it is available, and also the telltale evidence of insulin resistance is not there, and also other aspects which we now discuss. I think at this stage this will be, but if I see this patient with this profile, my diagnosis will be query type 1 diabetes mellitus, and of course, with the classical pattern, we'll initiate the treatment pending further points in the history and investigations.
Look for other syndromes also. In fact, there are now very rare types of diabetes. A number of types of diabetes associated with syndromes have been recognized. So young people, as Dr. Venkataraman was correctly saying, lipodystrophy is one of them. So all those things, probably history and family history is very, very important in this case.
With this provisional diagnosis of type 1, my practical question, if the patient is sitting in front of you right here, will you admit the patient or will you be treating the patient as an outpatient, sir?
No, patient is asymptomatic.
Sir, ketones are negative, asymptomatic. So, will we admit?
I won't admit, but definitely I will start the patient on insulin.
Evidence of metabolic decompensation, patient having ketonuria, breathlessness, I think this will be an indication for hospitalization, not for evaluation and stabilizing the anti-diabetic treatment. Certainly, hospitalization is not warranted in this case.
To at least remove the element of glucotoxicity, I will start insulin. Maybe once then go back to the history and other things. And if we feel that it is not type 1 diabetes, I can always go back to oral agents.
So having decided,
the issue is that there is one more thing. Is actually even the young type 2 diabetics, where they present violently with ketonuria, and then we treat them initially with insulin, and after that we can withdraw insulin, because looking into C-peptide levels and other insulin resistance syndrome features and all. There are reported cases to state that even type 2 diabetes in the young can be present with DKA, and then they'll be reverted back to type 2 diabetes.
yeah.
Some of the Western countries have now started reporting obese type 1 diabetes. I think especially the Scandinavian countries, there was a recent article. They say obese children can develop type 1 diabetes. So that is also there. So I think it is a real challenge from what you have presented now to arrive at the correct type of diabetes at this stage. Maybe when you give more data, especially the biochemical picture, then maybe
So obviously we require more data. So in that context, when we want to evaluate this patient, what are the diagnostic investigations which will be helpful to find out whether this patient actually fits into a type 1 or type 2, like that in this particular patient? Obviously we have to investigate this patient. What type of investigations can be helpful here, sir? Your inputs on this.
GAD65, insulin.
So you
and
want to do
C-peptide assay,
autoantibodies.
insulin assay, and also we have to do the genetic mapping for MODY. These are the three things we have to do it.
So if GAD is positive and C-peptide, that will give you ultimately what type of diabetes the subject is having. And as he said, maybe genetic if you suspect. Now MODY is diagnosed only with genetic testing. So clinical history alone is not enough.
So to start with, apart from the usual investigations what we do, always autoantibody and C-peptide will be helpful. So you want to sum up this?
So you want to, how to look at the C-peptide, sir? Why do we need to ask C-peptide? Why not ask for a serum insulin?
Because, insulin levels is because you are not treated with any insulin so far. Insulin itself is sufficient. But suppose if you already put, Dr. Venkatraman was telling that I would like to put them on insulin because thinking it's type 1 query, in that case probably we need to go for C-peptide rather than insulin assay. That's the reason I said both insulin and C-peptide assay keeping in mind. At this, as a untreated patient, you can go for insulin assay itself. But mind you, only thing is that when the blood sugars are very high, this can have a low values, and then once after treatment, you can improve on C-peptide and insulin level. That's also we have to keep in mind.
It's necessary that do the initial C-peptide, treat, and then again do the C-peptide.
So when the patient is presenting like this, should I ask for, with the sugars of 380, should I ask the C-peptide at that point of time, or should I come to a euglycemic stage and then ask for a C-peptide, sir?
You are thinking in terms of type 1 diabetes, I will do it at this stage,
sir.
C-peptide. Then once it is either elevated or normal, then maybe.
So the point that we should carry is like C-peptide should be followed up. Not that just because you have arrived at a C-peptide stage, you are not supposed to do 3 months later or 6 months later. Keep following C-peptide. That is a very important fundamental message. C-peptide scores over seeing serum insulin because serum insulin undergoes first pass metabolism. It gets metabolized in the liver. So you can't really pick up like how much insulin the patient secretes. C-peptide is a long-acting peptide which is there in the body for a longer period of time. So C-peptide scores over insulin at that point of time. So C-peptide has to be seen in interval. One reading will not suffice. With this understanding,
I think Gauri, why Dr. Gauri Shankar asked for should we do C-peptide at this stages, we know that in the context of type 2 diabetes, when there is a suspicion of diagnosis, glucotoxicity can impair the insulin secretion.
Correct.
So try to eliminate the glucotoxicity, bring down the blood sugar level, and then it will be much more worthwhile and meaningful to do a C-peptide so that eliminating the glucotoxicity, as Professor Madhavan rightly mentioned, I think if you are diagnosis. So in the sequential testing, priority will be autoimmune antibodies with respect to GAD, islet cell antibodies, insulin antibodies, etc., and a C-peptide. So that will give some clue whether it is type 1 or probably at that stage. So even in the absence of antibodies, you can make a diagnosis, because if you are lucky enough to catch the patients early, your chances of at least having one antibody positive or high, but down the line, after 6 months, 1 year, 1.5 years, like this case, they may be negative.
So the absence of autoantibodies doesn't rule out type 1 diabetes. That is very fundamental.
Correct, sir.
After some time, it may become negative.
Higher the antibodies, the better it would be. So GAD will be present only in 90% of the patients. So we might not be seeing the other autoantibodies. There are ICA, IAA, zinc transport antibody. So higher, if the patient is positive for 2 or more antibodies, the chances of type 1 is higher. As Sir said, just because GAD negative, it doesn't mean that we have ruled out type 1 also. That is something which we again need to remember.
Yeah. So we have got the family history. You can see father had diabetes, but at a little later stage, at the age of 48 years. Otherwise, mother did not have diabetes, and autoantibodies was done. All these autoantibodies were negative for this patient, and again C-peptide was done. You can very well clearly see that C-peptide is well above the, there is good amount of insulin production is there, so there is no doubt about it, and already we have done a ketone which is actually negative. So with this, what can we conclude? So a young diabetic having a high blood sugar, having high HbA1c, but now with good C-peptide, autoantibody negative. So what could be the diagnosis, and what else you want to ask?
This is what we have seen after 1 year. So again, GAD is negative. She has continued to have C-peptide normal. So do we need to say that she is a lean type 2 and start her on, continue to start her on OHA, or should we still have the suspicion of type 1 and keep her on insulin, sir? So with this phenotype.
With this C-peptide, we definitely rule out after 1 year.
Yes,
we
sir.
rule out type 1 diabetes.
Sir.
So it's very unlikely that this patient is a type 1 diabetes, or probably a very rare presentation of type 2 diabetes at a very young age. But I don't think even at this stage I will think of oral agents in a 19-year-old girl. So I'll still go for insulin at least for a short period to overcome the present scenario, and then maybe switch out to oral agents.
Absolutely.
No, absolutely. I think, and other thing is that what we need to understand is that whether it's a MODY or a type 1 diabetic, where now the type 1 diabetes has been excluded, then you have to differentiate between a MODY and a type 2 diabetic. And initially, after giving insulin, glucotoxicity, as Professor Venkataraman said, glucotoxicity comes down. I think sulfonylurea can work on both the situations. So MODY will also respond to this thing, and even type 2 diabetes, probably I will do with that, because you can always think about metformin, but she's quite lean. That's what I was just thinking.
No evidence of any
insulin resistance.
No, I think at this stage, as a clinician, you can say probably it's a non-type 1 diabetes. That is from the way of labeling the diagnosis. We are just going methodically as the case has been presented to us. It's a non-type 1 diabetes mellitus. Now, if you look at the hierarchy of the classification of diabetes, it was insulin dependent, non-insulin dependent, type 1, type 2, the various syndromes, secondary diabetes, etc., etc. Now, when we talk about the classification or labeling or giving a label has got lot of prognostic as well as therapeutic implications. Now, this patient certainly requires insulin, even though she may be type 2. Okay, she is a non-type 1, because this amount of glycemic deficit cannot be captured by any OHA, right? Having started her on insulin, if you feel that the requirement is more, then probably you are justified in adding whatever OHs you deem it as relevant in this particular case. So here I think this is not a clear-cut case, as I told you, as given in the textbooks. If the BMI were 27, you would have jumped saying this is a type 2 diabetic subject, let it bring down the body weight, anti-obesity measures, etc., etc. Here it's a normal BMI and no decompensation, no evidence of type 1 diabetes mellitus, but the blood sugar is high. So on the one hand, you have to give importance for giving a label which is in tune with the presentation, with your understanding of the knowledge, with the available clinical investigations, and then follow the patient. Second is correct the hyperglycemia. So even though it is, I think one of the questions that you asked is whether the correction of the infection will have any effect. Now, the old school of thought, from which all of us have gained a lot, I think Professor is there. So they say balanitis as well as vulvovaginitis, probably they anticipate diabetes. In other words, patients who are destined to develop type 2 diabetes mellitus, in other words, even though you cannot take it as something like a, what shall we say, as a dictum, there is an understanding that these two entities are probably solely present in the type 2 diabetic subjects, and sometimes they may even antedate the diagnosis of type 2 diabetes mellitus. Coming back to this case, a non-type 1 diabetic subject, yes, excepting for the BMI, I think probably everything is there for a young type 2 diabetic subject label to be given. But from the point of view of management, insulin plus or minus OHA.
So no, but the last question for clarification. Now we need to have a working diagnosis. It's a very ambiguous case. So working diagnosis is either type 2.
Working diagnosis you can say a diabetic with preserved endogenous insulin response. That's what we do. I think you have to be more pragmatic. I think it's a very good, what I thought was very apt diagnosis will be a diagnosis, instead of calling type 1 or type 2 or anything at this stage, diabetes with preserved endogenous insulin response. I think that will be a...
Down the line, can there be further reduction in the insulin secretion? And she may ultimately become either a type 1 or even we have to think of LADA. Of course, the age militates against the diagnosis of LADA, but I don't know whether we have to consider that also.
Can we, I mean it, just for the completion and discussion sake, a lean person with a high sugar, can it be a pancreatic diabetes? Can it be a pancreatic diabetes?
History-wise, there is nothing.
Most of the pancreatic diabetes may not have any steatorrhea. It may not be there. We need to think. That's the reason, sir, I am asking for working diagnosis, provisional diagnosis, diabetes in the young, type 2 diabetes, and MODY and pancreatic diabetes, that is type 3C, what you call type 3C. And then any other diagnostic criteria would you like to add for that?
I understand your ultrasound was done because you mentioned about PCOD. Which is normal. So ultrasound didn't show any pancreatic calculi.
Yes, sir.
So plus the fact that clinically she, of course, as you said, steatorrhea may not be there always, but abdominal pain and steatorrhea are the most important clinical criteria for diagnosing pancreatic diabetes.
No, ultrasound has been done for this.
Ultrasound was done, sir. Ultrasound normal, X-ray normal.
I missed it, yeah. Okay.
So before we proceed further, I'm not too sure whether any of us mentioned it. Evaluation of thyroid function test. Sir. I think any diabetic patient, more so in the younger age group, especially with this sort of a presentation, certainly calls for the evaluating the thyroid function. And of course, as and when other antibodies are being relevant, you can always consider, but at least thyroid for T3, 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 T4 and TSH is must in the workup. Yeah, please go ahead.
So the lessons that we learned here is, as Sir said, it is a preserved beta cell is there, but autoantibody negative. It doesn't mean that on management, we have to treat her just as a type 2 with OHS. Always keep in mind that it could be MODY, but MODY was ruled out because there was no vertical transmission from the parents. Since there was no parental history, both mother and father, they are educated. Father is a diabetic at 48 years.
No, that doesn't matter because we know that the successive generation type 2 diabetes occurs earlier.
So, correct. So that we wouldn't have, actually we should suspect MODY here. So that is the lesson. And we will work up and we will let you know like whether we are able to pick those genes. But this is the final carry home message. Type 2 with OHS and insulin, and she is being treated. Now we will, as we move on to the next case, we will come to Miss Anu, 2022. She is aged 13, weighing about 48 kgs.
Can you just sum up the first case?
Sir.
So the first case, just for reiterating, it's a real case captured in the clinicals of, I think, by Gauri and Rajesh. So there are a lot of things, as I keep on repeating it, which could have been avoided, but we took it wantonly because this is the situation that you and I have. We have a textbook description of cases, but sometimes we do have cases like this. So the workup says autoimmunity negative, endogenous insulin preserved, severe hyperglycemia. You have to treat the diabetes, and then at this point of time, probably it's a normal or lean type 2 diabetic subject, but because of the hyperglycemia, you take the participation of insulin in whatever schedules you deem it appropriate for this patient, and then take the help of OHA. This is from the management point of view. Yes.
In fact, in some of the cases, we always teach students that it is not necessary to identify the type of diabetes at the first presentation. You treat the hyperglycemia, then always later you can, in cases like this.
Sir. Yeah. So we will go to Miss Anu, who is about 13 years, 48 kgs, BMI 21. Her menstrual cycle is normal. Phenotypically, she didn't have any insulin resistance. There was no acanthosis. There was no viral tag, and HbA1c was about 11. We didn't have any C-peptide or autoantibody at that point of time. So earlier she was admitted for LRI and she was treated as type 1 DM on basal bolus therapy. All these are all previous histories. So she was requiring about 1 unit per kg of insulin, which is though it is required like slightly higher at that point of time. She has a very poor socio-economic history. Her father happened to be a daily wage, and she lost her mother in 6 months of life. So the history says, her father says she also had diabetic and she died of sudden cardiac arrest. We don't know what sort of diabetes at that point of time. The grandparent, maternal grandparent history also says that they had comorbidities, and they also died because of diabetes related complication at quite young age. That's what the father gives. Now with all these things, with no C-peptide, no autoantibody, HbA1c of 11, no insulin resistant, a thin individual being treated as a type 1 with a basal bolus therapy. And then subsequently she was seen by an endocrinologist. So the endocrinologist did a GAD antibody. She continues to have an HbA1c of about 12 or 13 over there in 2022. And she did GAD antibody negative, and since GAD antibody was negative, she was started on metformin with sulfonylurea. So she excluded type 1 over there, and her sugars are uncontrolled. So always the HbA1c is about 12 in spite of being basal bolus therapy. So she was put on metformin and sulfonylurea along with same dose of insulin, and now there is a fair control. So with adding on metformin and sulfonylurea. So Dr. Rajesh, you want to add something over here?
Yeah, the case is very clear, but only thing what I wanted to ask, let us ask from the panelist here. So here you have a school-going kid, 13 years, having very high blood sugar, initially was considered as type 1 diabetic and started on basal bolus. Subsequently, just with GAD negative, just knowing that GAD antibody is negative, without doing a C-peptide, she was started on oral drugs. So this is the scenario now. And now after starting oral drugs, it is fair under control also, blood sugar is. So with this history alone, without doing obviously we have to investigate further, but with this history alone, with this data alone, what can we say this patient is having? Whether this patient is having a type 1, really as she was diagnosed previously, or it is a type 2 diabetes, or we have to look into some kind of MODY-like feature. What does it fit into?
And I think the age onset at 13 years will indicate itself with a HbA1c of 11 and even GAD antibody negative, still can be a type 1 diabetes because it can be a seronegative type 1 diabetes can happen. It's not that 100 out of 100 type 1 diabetics will have GAD positive. There are GAD negative type 1 diabetics are also possible. Probably I think if you have some C-peptide assays, already patient is on insulin, probably C-peptide assays could probably give us.
But at this point of time, do you think it is
I would like to
sir?
treat it as a pure type 1 diabetic.
But once you say type 1, there is a serious concern about adding oral agents.
No, but the catch is that, but after starting oral antidiabetics, she gained control.
No, the control may be not because of sulfonylurea, probably because of the metformin, probably.
Whatever it is, but
with oral drug, she didn't have any insulin resistance at all, sir.
No, that's what I am telling. There is no insulin resistance at all.
As he was telling, is she a MODY, sir?
No.
3 generation of family history.
No 3 generation. You said mother, but we do not know about the maternal
side.
You said some comorbidities. You said comorbidities.
Because the socio-economic history means they are from such a background that we are not able to tell the history.
Capture it.
No, Gauri, even if you have a three generation transmission, the age at onset is 13 years, which will most unlikely be a MODY.
Okay, sir.
Age militates against MODY, but
very
the fact that she responded to oral agent, it is well known that many children with hyperglycemia unfortunately go on getting insulin for a long time. Until recently, we did not recognize the prevalence of MODY. Now we know that MODY is very prevalent now. So after the availability of the genetic testing very freely, I think many MODY cases are being diagnosed. But the only thing is the age, 13 years. That is very unusual for a MODY.
So I think the importance or the clinical relevance that you give for an investigation should be very, very careful, very, what shall we say, evidence-based. Now, presence of GAD antibodies tells you there is autoimmunity going on. Absence of it in a 13-year-old individual, I don't think gives you the freedom to introduce OHAs. A 13-year-old girl, in spite of the GAD antibody being negative, yes, it is negative, still my diagnosis will be query type 1 diabetes mellitus. I think we have to amalgamate the science that we have with our own clinical prioritization of the GAD, the tests that are available. So, I repeat, in a 13-year-old girl, absence of GAD antibodies, I don't think the clinician is justified in adding an OHA, especially in somebody who has got a BMI of 21, age is 13, and with a blood sugar very high, HbA1c is 11. So still it will be.
Sir.
So one more thing.
Even assuming that this is a very rare case of type 2 or MODY, I think as Dr. Venkatraman was telling us, I think there absolutely no indication for all ages.
So after 1 year we are saying, sir, you can complete.
No, after 1 year, I think, how do you say that before coming, according to the history that they said initially they were not under good control, after adding OHA is under good control.
That was the time, sir, 12.7.
No, but 13.7 to 11 and again 12.7.
No.
After that HbA1c was not done. Blood sugars came down.
So August 22, we did the GAD antibody. And then after December 12, 22, since the HbA1c was not getting control, she was seen by the endocrinologist and was started on metformin with sulfonylurea. We did a CGMS over there. In 23, CGMS showed that it was all getting settled.
No, but basal bolus therapy was also
basal
going
bolus
on.
Was continued.
After coming to you, did you give a proper delivery of the insulin?
Escalate the dose.
Escalating the dose, number one. Number two, proper, whether she was taking proper, motivation. A child with a type 1 diabetes taking basal bolus therapy requires a lot of education about not missing the dose and taking the insulin and appropriate way of taking insulin. I think you could have done that, and that could be the reason for good control.
I didn't see that patient at that point of time, sir. I saw after seeing the endocrinologist. Endocrinologist already started her with this parameters and with GAD negative. She started on metformin and sulfonylurea, and she said the control is fair. I saw the patient at that point of time. But my question is, sir, so the working diagnosis should be type 1 in this patient. So if the C peptide is normal, can we allow to continue her on OHS, sir?
Now, what I thought was, had this patient been, say, 21 years, BMI is 27, certainly my priority will be to de-escalate the dose of insulin gradually with gradual addition of insulin sensitizers, obviously, especially with telltale evidence. So there I think these phenotypic features like your BMI, presence of acanthosis or PCOD, and then your other history will be suggestive of superadded insulin resistance that will go hand in hand with your GAD antibody negative for you to have a firmer diagnosis. But here again, with the younger age of 13 plus 2 years after she has seen you, plus the BMI is 21. So HbA1c being very high, all the values are in the vicinity of 11, 12 and 13. So I think all these preclude for number one, a diagnosis at this stage of type 2, and number two, for the introduction of OHS. And I think I am sure senior clinicians are there. In cases like this, you and I have started on insulin, they have disappeared from your clinical practice and then reappear after 1 year. Somebody has started them on OHA and they are doing well. Is it not? It is not at all an anecdotal experience. We do. Yeah. At the end of these two cases, we'll have the audience participate, then we'll go to the third case. You're right. I am very fond of LADA. Do you think here you will think of slow onset type 1 diabetes or LADA?
But again, age of onset
is
13 years.
We talk about type 1.5.
Sir.
So age of 13 years onset.
Again, I know. We always say 30 years for LADA. But sometimes, rare instances. Or type 1.5. There is
so in that context, do we have to do any other antibodies to find out whether it is LADA or not, sir? GAD is
type 1.
I think all the other antibodies
GAD is
disappear
80% of the cases GAD will be positive.
All the other antibodies, they disappear faster. If at all you have a chance of picking up some antibody after late in the stage of the disease, in my opinion, I think it's a GAD antibody. Velu, am I right? Yes.
No, the fact that she responded to oral agent again gives us some that this may not be purely a type 1.
In fact, in the literature, there are some data. If you look at the type 1 diabetes mellitus, brittle diabetes. So, metformin is suggested as an add-on therapy for type 1 diabetic subjects to smoothen the control. This is there in the earlier books of pickup also, when there is a chapter on brittle diabetes. In other words, there has been attempts to introduce OHS even in the labeled type 1 diabetic subjects, but with respect to the consensus opinion, what is the prevailing treatment, I think excepting for the alpha-glucosidase inhibitors, we are too hesitant to introduce OHS when you entertain a clinical diagnosis of type 1 diabetic subject.
The alpha glucosidase inhibitors has been introduced even in DCCT, if I remember right, for type 1 diabetics to avoid nocturnal hypoglycemia. That's what has been reported. Only for nocturnal hypoglycemia, where they have to continue the same amount of insulin, but they are getting into nocturnal hypoglycemia. But at that time, we didn't have the analog insulins that much during that time. That's about 30 years ago. Now that problem will not be there because you asked for alpha glucosidase inhibitor.
So before we proceed further, I want the organizers, now it's 12:55, can we go on till 1:15 if the audience and the organizers are comfortable? Yes, sir. Is it okay? Yes, yes.
1:15.
Fine? 1:15? Yes. Okay.
Yeah.
Please go ahead.
So just to re-emphasize the point which Professor Venkatraman sir said, young patient having high blood sugar initially treated as type 1 diabetic and GAD was actually negative. Without looking into the C-peptide level, without knowing whether there is a good insulin reserve, starting an oral drug may not be advisable at that point of time. Maybe this patient would have responded well, but we cannot take it as a prototype and start oral drugs for this kind of a patient without looking into the C-peptide. So with this in background, C-peptide was looked for this patient. Patient had a very good C-peptide level. You can see it is the stimulated C-peptide is 7.86, which is well above the lower range, and you can see, and then the patient was, since there is a small itching in mind for Dr. Gori, because he was the one who treated this as a third doctor. So since there was some kind of a younger onset diabetes in the family with the grandparents as well as with the parents, so patient was subjected to genetic testing for MODY. But unfortunately, we couldn't pick up anything. All these genes were not positive, it was only negative. So, can you sum up and say what was the lessons learned from this patient?
Sir, what we
yes.
learned this case with C-peptide normal, still we have a working diagnosis of type 1. With the C-peptide continue to be normal, are we justified in giving OHS to this patient or not? Or in case if there is a good control after giving OHS, so can we withdraw OHS at that point of time? Because the patient was responding.
Withdraw insulin.
So the patient was, no, OHS. So
you said
because
good
control
with good control OHS.
No, see.
with good control with OHS and insulin. Okay. So now can we so still our working diagnosis will be type 1. So when as a clinician we see, can we withdraw OHS at that point of time and put the patient only on aggressive basal cholesterol?
Having so much of C-peptide,
No,
you want to?
I wish there is some C-peptide value earlier as well. Whether they had a higher C-peptide at that time and then coming down, it can always come down over the time. Like slow onset type 1 diabetes. Dr. Madhavan was also telling. Maybe did you check again after a few months or something like that C-peptide again or?
2 C-peptides we did, sir. Both the C-peptides were same. 2 GAD antibodies we did. Both the GAD antibodies were negative.
No, how many years later? How many months later did you check
Sir, around
C-peptide?
same, sir. 6-7, sir. In January we did 2023. C-peptide was 6-7, and that time it was getting control, and after that it was very good control. HbA1c was achieved. So that time again we did the C-peptide just for follow up. That C-peptide is the one which we projected in 2000.
Earlier C-peptide? 6 months
sir,
earlier?
around 6-7, sir.
That is very interesting.
Very interesting. I think before we proceed further in a lighter vein, both I think Gauri and Rajesh would have given us some easier cases for the they are testing the clinical expertise as well as of course, I think it's a food for thought. We have to accept the realities. Otherwise, I think both of them would have had clear-cut cases wherein we have the diagnosis of a young type 2 diabetic subject, a type 1 diabetic subject, a MODI, etc., etc. So this calls for discussion had it been like that, so that we have, I think the message that I think Gauri and Rajesh, plus of course with the approval of my fellow panelists are, so when you talk about an young onset diabetes, there are two aspects. So you have the four combinations. One is autoimmunity positive or negative, the next is beta cell reserve is absence or negative. So in both these two cases, the working diagnosis rules out probably a type 1 diabetic subject. That is from the point of view of semantics, if I could say so. You have to label. But from the point of view of management, a 13-year-old girl with HbA1c of 11, I think you'll probably your focus will be to maximize insulin, probably take the help of OHA after explaining to the patient that this might help you to bring down the dosage of insulin. And in both the cases, I think, even though they are quite young, especially the second case, she is just 13 plus 2, 15 years. The first one is 18 plus 2, 20 years. So both of them, the family should be trained in such a way that these are going to be girls, women in the reproductive age group, raise a family, and then the pre-pregnancy counsel should be started being a girl child. That is my point of view. So at this stage, I think the workup has been there. Probably the workup of MODI, I would have entertained even in the first case because of the age of onset. I think you have done it in the second case because whenever you have the opportunity to see the case, I think I would again like to remind the audience that these cases have not been followed up right from the beginning till the presentation by both of them. It is in between they have had the exposure and they have captured the data and how we would have reacted had we seen the patient at these stages of the disease with the available investigations. Yes, I think the workup is complete, the message is complete, but from the point of management, absolutely, I think your clinical knowledge that hyperglycemia has to be controlled, the focus has to be on insulin in both the cases.
In fact, I have a few cases, about 10 to 12 cases, which are adult onset. In the sense, adult onset is around 30, 25, like that. Most of them come into the back, right? And then they had a very good C-peptide all through. In fact, almost about 5-6 times every year I used to do that. But they can never got under control with oral drugs, including pioglitazone such sensitizer. They did not. They required a combination of insulin twice a day, because they are not type 1 diabetes, basically GAD negative only. Everyone is GAD negative. So we used to have two injection doses plus all the oral drugs. Only then we were able to control. It is very difficult to explain that. In spite of having a very good C-peptide, they don't come under good control with oral drugs.
In fact, Dr. Morgan Center, along with somebody from Norway, last year I think, remember, they have come out with 6 types of presentation in Indian phenotype. Yeah, what do you call that? Clustering of. So there are Indian phenotype is very, very heterogeneous. I think we cannot compare with the Caucasian population and say ours is very different.
So here also you cannot classify them as syndrome of defective insulin secretion because both the C-peptide are good enough. I think it calls for. I think before we proceed to the third case, if you allow maybe a couple of comments from the audience. We have senior diabetologist physicians here. Our chief guest is there. Yeah, anybody from the back who want to have a question? Maybe 2 or 3 questions before we go on to the.
Apart from GADA, there are other prognostic markers like.
1 minute, I think he is making a.
Mike.
So apart from GADA to
please introduce yourself. Please introduce yourself.
I am Dr. Jnanashekaran.
Yes, I know. Yeah, please go ahead.
Apart from GADA to diagnose type 1 diabetes, what about islet antigen 2? There is another marker and zinc transporter 8 marker. We could have done that so that from the back of the arm we can arrive at the diagnosis.
Available, sir. It is expensive. It is not widely available. 90% of the time we can go with GAD, but sequential GAD we have done. GAD costs 1,000 rupees if you do it in MGR Medical University, whereas the zinc transporter, I think it costs about 10,000. The islet cell, IAE and all cost about 4-5,000. I went with the cheapest one. We did it sequentially for both the patient. It was negative. So for practical purpose, GAD alone will do.
And Gauri, out of the 3 you mentioned, which one persists longer? That is also very important, because both the cases
GAD,
you have seen, GAD is the
GAD
only
persists
thing
longer,
whereas the other antibodies can disappear very early.
Oh, okay.
Any other question or comment before we go on to the other cases? Yes, please.
Sir, HbA1c 3 months once we'll do, sir, like that for GAD, and they said C-peptide. What is the interval for follow-up and all, sir?
No, that is a beautiful question. As I have known of, there is no protocol. But in this particular patient, with the index of suspicion of a progressive nature of the beta cell dysfunction like type 1 being very high, so let us not stay put with just one value of C-peptide. Down the line, when you have resistance to control, try to control and then repeat the C-peptide so that you can document this patient had an initial, probably a good, robust C-peptide response. Now it has come down. Now you know the diagnosis and how to go about it. It's a beautiful question. I think it's your clinical discretion.
Repeated after 1 year or what interval?
No, that's your clinical discretion.
No, once you get a near normal glycemia, probably you can repeat a C-peptide at that point of time, because initially when the patient is having glucotoxicity, your beta cell function may not be that very apt, so you may have a very low C-peptide value. So once you start an insulin, whatever is the type of diabetes, once you get a near normal glycemia, then that is the time you will get a better idea if you repeat it. It may be even after a month, it may be even after 3 months, it's up to us.
You may ask why we did GAD antibody twice. There is a recommendation from, I think, Norway or Canadian guidelines, where they say, like, if you are going to diagnose only based on GAD, so you repeat it in another lab to see what has happened. So that is what we did.
Another lab.
If you are going to diagnose based on 2 or 3 antibodies, it is better. But repeating means GAD twice, it costs 2,000 rupees. If you want to ask another antibody, it is going to cost you 5,000 rupees. So that's where.
So economically, it is good.
Yeah, I think when we approach a patient, that's what we do in practice. The clinical knowledge is there, our experience is there, and the patient is there. So we have to balance everything and then order for the investigations for you to have a working diagnosis, a substantiated diagnosis. And then a comment from Velu before we go to the third
yes,
yes, Velu.
As pointed out by Dr. GVK, he has tried most of the tablets along with the twice-day insulin also. Such patients, I have added imiglamin that showed very remarkable improvement. I have used imiglamin in more than 400 patients. I have come across significant improvement with reference to fasting postprandial as well as A1C, and the insulin dosage has come down drastically also. That is imiglamin. And I do come across obese patients with the type 1. On the background of patients, both the parents are type 2. And this patient, type 1, after started giving insulin, that patient tend to develop obesity also. But GAD positive, C-peptide very low, both in the fasting as well as post-meal. And yet another patient, next is, that is, you told, do C-peptide initially, repeat after some time. One particular doctor did C-peptide initially low, started on insulin. After 6 months, C-peptide level came up. So he stopped insulin. Automatically patient started developing same hyperglycemic symptoms. So that patient came to me, I told, initially C-peptide low, after giving insulin, there is still some, beta cells are viable, this can secrete, the so-called honeymoon phase. There will be temporary improvement, fasting and postprandial. This will remain for a short period of time. After that, automatically. Our aim is to preserve such beta cells also. C-peptide positive type 1 in the long run. Definitely retinopathy, neuropathy and nephropathy incidence are less. That's what we normally convey to our patient.
I think you have brought in a very important point, the honeymoon phase. It's a honeymoon phase can be up to 2 years, I think, maximum 2 years, not more than that. So I think till then you have to be very careful, keep on, as you said, that keep on checking the C-peptide, but continue to be on insulin to just overcome the honeymoon period.
I think these two cases, as has been nicely exemplified by additional inputs from Dr. Shanmuga Velu. Yes, there are two aspects to the approaching this patient. One is your pursuit, your endeavor to arrive at a etiological diagnosis. So we have done from the clinical history, from the presentation, from the available investigations you have. The second is, whatever be the label, just because the C-peptide is positive, do not ignore the glycemia, the HbA1c. In other words, treatment. I think when it comes to treatment, the very fact that the C-peptide is positive gives the clinician a cushion to think about at this stage about introducing the OHAs, like for example your metformin, imiglamin. Yes, I totally agree with you. So it gives you a scope. So there are two aspects of management of this. One is a diagnosis, your attempts to arrive at a diagnosis. The second is your attempt to control the glycemia. I think that's what the exercise we have learned, and this is a good, I think always worthwhile remembering. The message of this presentation is being caught up in this. So when you have a young diabetic, then look for these things: the presence or absence of autoimmunity, and then the level of the beta cell insulin reserve. I think that is a message that you have. Other things, I think all of you have adequate experience. Before wasting time, I think shall we go to the next case?
We can go to the next case. Yes, sir. So next case is. So here, this is actually an even more interesting case. You can see a 31-year-old male having a BMI of 30. I think Dr. Gauri has written Kattai there. You can ask him after the lunch period what is the Kattai means. So having a BMI of 30, age of the patient is 31. Initially he was seen, see this actually happened 2 years back, in 2021. He came to us somewhere in 2023. So 2 years before the presentation to us, he went to a senior diabetologist where, looking at the phenotype, OHA was started, and initially patient's blood sugar came under control, but once again it went up, he was drug was escalated there. So ultimately, by the time he met us, what happens is that he was on 5 oral drugs, including SGLT2 inhibitors, metformin, sulfonylurea, AGIs, and DPP4 inhibitor, as well as SGLT2 inhibitor was there. So this is his history. Family history, if you look at it, his father has diabetes for the past 10 years, but now the presenting complaint is that he has balanoposthitis. And look into the blood sugar level. Fasting is more, very high, 190, postprandial is 342, and HbA1c is 9.2. So this is the presentation. A typical type 2 diabetic individual on 5 oral drugs, not under control, with an infection. This is the presentation. You want to add anything to this?
So, sir, my fundamental question is, like, he has a balanoposthitis, severe balanoposthitis. So, should I ask him to undergo surgery because he has insulin resistance? So, once his treatment gets controlled, probably his sugar may also.
Before subjecting to surgery, I will withdraw SGLT2 inhibitors.
Sir, okay,
why is on
obviously.
SGLT2 inhibitors in a severe prostate?
SGLT2 are withdrawn. So, will I be waiting for the infection to control before putting him on insulin because he is reluctant? Or should we prepare him by giving insulin, treating him, because anyhow it will not get treated because he has such an underlying infection? What should be my approach? So should I ask him to get the infection treated, or is the glycemic control important at this point of time?
Glycemic control is very important. I think I will withdraw SGLT2 inhibitors, give insulin, control the hyperglycemia.
But he is suffering over there.
No, Gauri, you can see that. No, as Professor Madhavan has said, that you have to withdraw SGLT inhibitor. But believe it that it's 9-point HbA1c balanoposthitis. I think one of the indications for insulin therapy, even in type 2 diabetes, is this infections actually. So I think this is a case where before even diagnosing whether it's a type 2, type 1 or whatever it may be, I think this situation warrants a small dose of insulin, so the sugars will control better. Maybe balanoposthitis may improve even before deciding about the circumcision.
So having started him on insulin,
no, the issue is that 5 oral drugs did not control the diabetes.
Yes,
it was added sequentially, sir.
How many years of diabetes by then?
By this time and presentation, 2 years of diabetes.
For 2 years of diabetes requiring 5 drugs and then sugar not under control, it will give a lot of thinking about the diagnosis of this patient.
But at this KVT always used the word red herring. Some of you have been used to. So here the red herring is the BMI. So in this case, of course, Vijay said, yeah, there's a practical approach, control the glycemia. I think if the clinician who sees this patient, he or she is justified in making a diagnosis of obese type 2 diabetic subject. So even though sequentially it has been added, maybe that has been neglected, that the positive response to multiple OHs has not been there, but you are justified. I think it's a question of discretion, because you would like to introduce both a GLP-1 receptor agonist as well as an SGLT2 as early as possible in this patient to facilitate reintroducing the SGLT2. Certainly withdraw achieve the glycemic control with insulin, have the circumcision, and then the earliest opportunity, because you would like him to lose weight. Because now the data have emerged that be it obese or non-obese, first few years, 6 years of diabetes, huge weight loss, 5%, 10%, 15% can reverse diabetes. So these are all the messages, may not be relevant in this case, may not be achievable in this case. So with this, I think the aim will be to control the blood sugar level, and then at the earliest opportunity, introduce molecules and reinforce lifestyle in such a way that along with your glycemic control, you achieve a tangible weight loss, which is now quantified. So weight loss of something like about 10 to 15%, if you achieve it, then you can probably even reverse diabetes.
But Venki, in this case, with 5 drugs, this control is not good. What's the point in continuing the oral agents now?
Wait. See, in a similar forum, I tell you, lifestyle modification, weight plays a lot of role. I think we tend to ignore that. So, at this stage, I do not know about the further progress of this patient. With this presentation, my endeavor will be to push him to lose weight. Maybe he is about 5'8", probably he'll be around, say around 78 or so. So, or even more than that, 80, 82, the BMI is 30. So if he is going to be 5'8", 170 centimeters, his ideal body weight will be about 67 to 72. So there is a cause for losing about 10% of the weight at the earliest opportunity. I'm just giving an example. So once you do that, maybe the OHs which have been refractory to this at this time may start having some response.
I totally agree with you that he has to lose weight. But at this stage, you introduce insulin or not introduce insulin?
Obviously, I would want to introduce both the molecules. To facilitate me introducing the SGLT2, we need to have that disturbing factor of phimosis. So have the circumcision done. To facilitate that, yeah.
In fact, as Professor Venkatraman was telling, if you lose really 10% of the weight at this stage, 2 years of diabetes, I think there will be a remission in diabetes is possible. If it's a type 2 diabetic, and 2 years and remission.
Vijay, can we talk about remission in a person who has A1C of 9.2
no,
with 5 oral agents?
No, sir. The power of LSM. Hopefully, I'm not talking about this patient, but in general, if they lose 10% of weight, if it's a type 2 diabetic, the remission is possible.
At any stage of glycemia, any spectrum of glycemia?
No. Initially, we need to control, and then we can withdraw that. 10% weight reduction without drugs is the most important thing.
I agree with you, Dr. Vijay Kumar, but in this index case, do you think we can talk about remission? I don't know.
Not in this situation. No, I'm talking about not this situation, because Professor Venkatraman raised the issue of 10% of the weight reduction that can induce remission. That's what I'm telling. Not in this. In fact, I said you start insulin, control the diabetes, infection may subside. That's what I said.
Yes, that was actually done for this patient. This patient was actually subjected to circumcision with some antibiotics. Insulin was started, and as Professor Madhavan sir said, SGLT2 inhibitor was temporarily withdrawn, and you can see he was started on insulin. But what happened is that his insulin requirement was very, very high here. It went up to even 1.5 units per kg, and again he was continued on metformin with a DPP4 inhibitor as well as a low dose sulfonylurea was continued. But in spite of all these drugs, blood sugar did not come down. So obviously after few months, what happened? SGLT2 inhibitor was actually reintroduced after a period of 6 months, and then after that patient had good control. See, you can see from 9 point something to it came up to somewhere around 7.2, had a good control. So everything was going smoothly so far. You have any doubts to clarify here?
Sir, I have one doubt. Why was he requiring about 1.5 units per kg, sir? So
very high.
BMI 30, but a huge requirement of insulin with metformin and sulfonylurea, and even only with SGLT it was getting controlled. So it is usual for us to expect this much amount of insulin requirement.
In this context, can we think about FCPD in this particular case? 30 years.
No, because obese. FCPD is never, very rarely very obese.
But nowadays, due to lifestyle, you even have a type 1 diabetic having obese.
No, pancreatic diabetes are usually very, very
less
thin.
than 20.
No, only with treatment they may put on weight with insulin and other things. But as a case, a pancreatic diabetes is never obese.
In fact, it is well known that pancreatic diabetic subjects do not gain weight even with insulin. And of course, the requirement of insulin will be very high, but I don't think
correct.
Phenotypic
That's the point.
picture doesn't warrant a consideration at all. Of course,
Yes,
we'll do
yes.
always a ultrasound, etc. But regarding Gauri's question about the SGLT2, normal teaching is when you introduce SGLT2 inhibitor and somebody who is already on insulin, reduce the insulin dose by 20%. But in clinical situation, we have seen that the reduction in insulin dose is far much more favorable with the introduction of these molecules. Few things are there. Loss of adipose tissue, especially the loss of central adipose tissue, and much more, the much hypothesized level of action. They act at the level of the central autonomic nervous system. The autonomic flow is reduced when you have an SGLT2 inhibitor. Maybe more than one reasons, and maybe reasons which we have not yet identified. So in this particular case, the reintroduction of SGLT2 has been rewarding. Number one, the HbA1c is touching towards the target maybe for the first time in the last few years. And number two, I think you did mention that the insulin requirement also is coming down. So these are the two clinical endpoints which the clinician should be happy. Now we can proceed.
So I'll just quickly go through what happened to this patient. So everything was going smoothly for this patient, and even engagement was fixed for this patient. But everything was going smoothly till then. What happened is that 2 days before his engagement, what happened? He developed vomiting, and he reported to a nearby hospital for that. There they evaluated him, and eventually, looking at the condition, they even did a ABG for him, and we can see that he was in severe metabolic acidosis. His pH was only 6. Bicarbonate was something somewhere around 5, single digit. So this was the scenario. Had a metabolic acidosis, shifted to another hospital for again intensive care. But at that point of time, if you look into the HbA1c, it was still under control. It was still 7.3. On insulin, on oral drugs, including SGLT2 inhibitors. And this is where I just wanted to ask from the experts here. A patient whom we considered as type 2 diabetic, on insulin, on other oral drugs, fairly under good control. Obviously, you can see the blood sugar is under good control. There is no foci of infection here. So to push a patient to diabetic ketoacidosis, you need some kind of a precipitating factor. I don't. Obviously, betrothal will not be a precipitating
How much
factor.
of
betrothal?
Yeah.
How much of insulin was reduced when SGLT was reintroduced?
When SGLT2 was reintroduced, I'll just tell you, with the same dose of with the reduced dose of insulin, he was maintaining so long, so good.
It is well known that when you reduce insulin
Correct.
in a patient getting SGLT2 inhibitors, they can go into euglycemic ketoacidosis. That is why we always caution.
Yes.
Don't drastically reduce the dose
But
of
these
insulin.
things can.
No, sir, even with SGLT2 inhibitor, earlier he was taking 40 units of prandial insulin. Now it has come down to 32 or 30. That is what warranted.
But
Because
he
for
is not
finding
withdrawn
it,
during this time. No,
No,
the
he-
insulin was not
he was
withdrawn.
doing well with SGLT2 inhibitor and basal bolus therapy. For 6 months he was doing well with the 30 units of prandial insulin 3 times a day and 40 units of basal insulin. That was the amount of insulin he was requiring, about 130 or so. So we were able to reduce 30 units with SGLT.
The question here is
just
whether
a
it is
clinical-
euglycemic ketoacidosis or something else.
So,
Obviously,
a clinical recap of this patient is a obese diabetic warranting a label of type 2 diabetes mellitus, a family history of diabetes, presence with hyperglycemia and multiple OHs with poor response, had phimosis, had an intervention in the form of circumcision, SGLT2 reintroduced on top of insulin therapy, which was introduced to control the glycemia. The insulin requirement came down as expected, and the HbA1c started approaching towards the target value. At this point of time, without a provocation, he has an episode of diabetic ketoacidosis, warranting the clinician to undertake the exercise of questioning the labeling that has been given to this patient. Am I right, Gauri?
Yeah, see, in fact, the requirement of insulin is so high, sir. Actually, with oral drugs itself, the insulin requirement is so high that warrants about thinking about another diagnosis.
Correct,
definitely.
and with 5 oral drugs,
And, you know,
not under
I
control
want to ask you
initially.
one thing. Because this patient had a DKA, now we are becoming retrospectively.
No, sir. If you
Without
remember,
the DKA, will you have a rethink on the diagnosis? I don't think I would have.
No. The thing is that here, the Dr. Professor Madhavan has said probably euglycemic ketoacidosis. Yes, I agree with him. But when somebody is still on insulin, developing euglycemic ketoacidosis, is it because of SGLT? It's a big question mark. No. That's the most important thing. He was already taking up to 100 units plus even now.
Yes, sir.
Did he miss the insulin dose during that betrothal?
Sir, that is the climax here. So that is is what the
We know that SGLT2 inhibitors are off-label for type 1 diabetes. So somebody puts SGLT in a type 1 diabetic and then reduces drastically the insulin.
Obviously, then
Definitely
they
the
will
patient
land up
go
in
into-
trouble. But
Yes.
No. Sir, remember, sir, in the first slide when he's put it, I said, in spite of five oral drugs, 9.2 HbA1c, we should not think only about type 2 diabetes, something else we need to think about that. Remember, my state.
Yes, sir. Yes,
No,
sir.
I think in diabetes, the way the phenotype of an individual is presenting has been given a lot of importance, quite justifiably, that it becomes a disappointing. For example, had this patient presented to me at the age of 31 with a BMI of 22, with a high blood sugar level, LADA will be at the back of my mind. But with a BMI of 30, with a family history of diabetes mellitus, certainly type 2. Now, with so much of OHS being on board, the requirement being on board, as Professor Madhavan rightly anticipated, yes, should we call for a rethinking about the diagnosis? Yes, after this episode of DKA. In other words, in clinical medicine, you're always in for surprises. A seemingly a type 2 diabetic patient with obesity, with certain amount of hyperglycemia, and responding to multiple OHS and some insulin on board, has an episode of DKA. It calls for rethinking on the diagnosis. So anything can go wrong will go wrong.
Murphy's Law says, anything that can go wrong will go wrong. Only when you are hungry, the meeting will get extended. Only when things happen like this, his betrothal was scheduled, he was landing up with the DKA. Only when you want to attend the clinical meeting, you will have some 5 patients sitting outside your room. So things will go wrong at any cost. So in this patient, when his betrothal was scheduled, he was money crunched. So he was missing his long-acting insulin because he was not able to purchase it that time, costing some few bucks. So he was not able to afford. Second thing which happened was, he used to always give, not in the thighs or in his abdomen, he used to always get his insulin administered in the back for whatever reason, that is what he feels comfortable. Now before this episode, his insulin pen has broken. So with this broken insulin pen, he was administering, not knowing that the inside is made of glass and that can get break. So he's thinking that insulin is getting administered, but there is a crack through which the insulin was getting leaked. So because of that, he missed only 8 doses of insulin, and basal insulin he has stopped, and he's on SGLT2 inhibitor. So this predisposed him for this euglycemic ketosis, and with that pH 6, he was hydrated, and whatever was treatment, he got treated, and he attended his betrothal also, and he's doing now well. So this is the message and during admission, during discharge, his GAD was positive and C-peptide is negative. So if you see this patient from the first, like we didn't do a GAD antibody, but C-peptide was normal. So we thought that he will do well, but that was not happening. So as we said, the point that needs to be reiterated is, keep doing sequential C-peptide to see what is happening to our patient. Just don't get satisfied with one C-peptide. Rather, if you would have thought about doing C-peptide when he was recurring, as Vijay Kumar sir was telling, like as we thought at that point of time when he was taking SGLT2 inhibitor with such a huge dose of insulin, if he had thought about alternative diagnosis, he wouldn't have landed up with this euglycemic ketosis. That is the message that we got from this patient.
Is a LADA? Or
so probably it could be a LADA.
What label you are giving?
LADA turning out to be a type 1, sir.
It is LADA, but what happened, he was actually started on sulfonylurea also, that would have beaten up the beta cells. So gradually what happened is that he did not have any insulin reserve, and unfortunately for him, he stopped his insulin dose, and he was simultaneously on a SGLT2 inhibitor. So one part lack of insulin played a part here. Again, SGLT2 inhibitor also pushed him for a euglycemic ketosis.
Probably. Actually, yeah. See, if you look at the sequence, temporal sequence of what's happening in the pancreas with respect to type 1 or LADA, the autoimmunity starts, and then the autoimmunity goes up, then the beta cells are destroyed, and hyperglycemia. Here, I think the GAD antibodies were not looked up because the clinician cannot be blamed. I don't think you will would like to do a GAD antibody positive in somebody with a BMI of 30 with a family history of diabetes mellitus. Certainly you accept a diagnosis. So retrospectively, again, as Professor Madhavan said, when he is resistant to treatment with 5 OHS warranting insulin, maybe at that stage, again that BMI would have precluded the clinician from entertaining a diagnosis of a type 1 in this particular case. But of course, the clinching was the betrothal, and subsequent events, like we say, the many a slip between the cup and the lip. So many things have been happening. The syringe is broken. He has missed his long-acting insulin. He is on a SGLT2 inhibitor, even though we can call it as euglycemic or certainly a frank hyperglycemic diabetic ketoacidosis. Still, it calls for revision of the diagnosis, which has been established. So we come to the end of the session.
No, the caveat is that, you know, the LADA, who is an obese one, the caveat.
Exactly. So
that is what is most
when you
important.
look at the textbook, presentation 30 to 40, lean, probably no family history of diabetes mellitus, GAD antibody positive or at that point of negative. Sometimes GAD will be positive, the C-peptide will be good. So, in the presence of autoimmunity, there are some people who say that you are justified in continuing the OHAs. But let us take it in the reverse way. If you had started some patient on OHA in a suspected LADA, GAD positive, with the C-peptide subsequently becoming negative, retrospectively you need not feel guilty because you are justified. At that point of time, when you had a diagnosis, you probably thought it was a lean type 2 diabetic subject becoming a LADA. I think brilliant cases worked out by both of them. So I hope all of you enjoyed these presentations because these are clear-cut, real cases. I think many aspects were not comfortable for the discussion point of view, from the point of view of labeling or otherwise, but this is what has happened in the clinical scenario, and this is what probably we could have done, or probably something much more, had we seen that patient. I think that was the purpose of this exercise, and I think both Professor Madhavan and GVK, thank you so much for joining in this.
No, sir, thanks for you, number one, and number two, these two guys. Really, you gave us food for thought. No, it's ambiguous cases, you know, it's not straightforward cases.
Dr. Dhanmitra, Natarajan and Parandaman, please excuse us. I think we have exceeded the time limit, not by just 5 minutes, by 30 minutes.
Just one point I wanted.
Thank you so much.
Thank you.
Thank you very much. Let's give them another big round of applause. Okay. We will now adjourn for lunch. Thank you for joining us till now. Please stay tuned because we have some really nice talks in the afternoon and we would love to have you all with us again here in this hall at 2:15. Lunch is being served on the mezzanine floor in Varahari Halls 1.